Good morning, everyone. I'm Dr. Ulfat Awad of Nephrology. I'm gonna present a rare case in nephrology and hypertension diagnosed at Zahra Hospital, University Medical Center. The moderator of my presentation is the Professor Majd Ahmed. 43-year-old male patient, previously healthy, presented with marked nausea without vomiting. Review of systems was otherwise negative. He sought medical advice with a cardiologist since the patient had a recent history of flu-like illness that progressed to dyspnea and chest discomfort. So he sought medical advice with a cardiologist who did an echocardio and showed an ejection fraction of 25 to 30%. He was started on heart failure treatment without any laboratory workup, and he was not prescribed NSAIDs. All of this was as out basis. His physical exam was remarkable for hypertension, blood pressure of 180/96 millimeters of mercury, grayish metallic colored skin, which we usually see in uremic patients, left eye ptosis that the patient mentioned having many years prior to presentation, normal lung, heart, and abdominal exam, no extremity edema, no evidence of skin lesions or rash. Laboratory investigations: hemoglobin was 9.9, BUN 126, creatinine was markedly elevated at 12, sodium, potassium, and bicarb were disturbed as in usual cases of renal failure. Imaging: urgent uroscan definitely was done to rule out obstructive uropathy, and it ruled out post-renal acute kidney injury. The patient was admitted and started on hemodialysis. He was admitted to nephrology service for investigation and management of renal failure. Additional workup: his urine analysis was marked for protein plus, white blood cells 4 to 6, red blood cells 2 to 4, no casts. Liver enzymes PT, PTT, LDH, haptoglobin, bilirubin were normal. ESR was elevated at 43. Differential diagnosis: intrarenal kidney injury that could be due to glomerular, like glomerular nephritis, vasculitis; tubular, as in tubular obstruction, as in multiple myeloma; intravascular hemolysis, rhabdomyolysis; acute tubular necrosis that could be drug-induced; vascular, as in thrombotic microangiopathies, hypertension, scleroderma; and interstitial that could be drug or infection-induced. His serology for hepatitis and HIV was marked by the positivity of hepatitis B surface antigen. And since one of the most common renal problems associated to hepatitis B is the membranous nephropathy, 24-hour urine collection for proteinuria was ordered, and it was found to be only slightly elevated protein in 24 hours at 327 milligram per 24 hours. The upper limit of normal was 150 milligram per 24 hours. Echocardiography confirmed systolic dysfunction in our patient with moderate LVH and global hypokinesia, grade 3 diastolic dysfunction. During hospitalization, our patient had evidence of GI bleeding with melena and drop in hemoglobin. Gastroscopy showed erosive gastritis. What is the next step? What is the diagnosis to our patient? Still, it's unclear. The findings of renal failure, hepatitis B infection, GI bleeding, heart failure, hypertension raised the suspicion of a systemic disease, and all of this mainly fit the picture of polyarteritis nodosa. To confirm our diagnosis, we have several diagnostic modalities. Biopsy is definitely the gold standard from an involved organ. However, kidney biopsy is relatively contraindicated in patients with polyarteritis nodosa due to the high risk of bleeding from microaneurysms that are present in the renal vasculature. Angiography for renal and mesenteric arteries could be done. However, it's more invasive than the last two options, which are the MRI with gadolinium or angioscan. MRI with gadolinium was not done since our patient has renal failure with a high risk of nephrogenic systemic sclerosis, so our diagnostic image of choice was the angioscan. Abdominal angioscan showed a distal renal artery aneurysm at 10 × 7 millimeter This is the renal artery aneurysm, bilateral feriform aspect of renal arteries, and significant narrowing of the left renal artery as it progresses to the hilum of the kidney. So this is the left renal artery, this is the right renal artery. The left renal artery, as it progresses to the kidney, it becomes very narrow and thin. This confirms the diagnosis of polyarteritis nodosa. Treatment. The appropriate treatment of severe polyarteritis nodosa is steroids and cyclophosphomides. But since our patient had recent GI bleed and hepatitis B infection, steroids initiation was postponed until 2 weeks after treatment initiation for hepatitis B. So what is polyarteritis nodosa? It's a medium vessel vasculitis, mainly idiopathic, but could be secondary to infections like hepatitis B or C and hairy cell leukemia. Involved organs include skin, kidneys, heart, joints, muscles, GI tract, but it has a striking tendency to spare the lungs. It's a rare disease at a prevalence of 2 to 33 per million, male to female ratio 1.5 to 1. However, the introduction of hepatitis B viral vaccination resulted in a parallel reduction in the prevalence of polyarteritis nodosa. Diagnostic methods are already discussed during the presentation of the case. Treatment decision depends on the severity of the disease, mild versus moderate versus severe, association to hepatitis B or C, single or multi-organ disease, and treatment options include steroids, cyclophosphomides, azathioprine, methotrexate, mycophenolate, or rituximab. Thank you.